Hello, and thank you for joining this session about our organization's experience designing and implementing a learning health system model. First, I'll quickly introduce the Alberta SPOR Support Unit and our relationship with Alberta's learning health system. We are a research and KT intermediary established to support patient-oriented research and implementation. Our mandate is to build partnerships and support services to bridge the gap between evidence and practice, and to leverage those partnerships to support Alberta's learning health system. So given this mandate, an important part of our organizational structure is that we have a co-leadership model with folks sitting in those leadership roles from both academia and the health system. And in this way, we're able to leverage both scientific and practical knowledge in the province. So the way that I've organized this presentation is I will give a high-level overview of what learning health systems are and how our model fits, and then the story of how we came to that model. So first, here is an incredibly helpful Canadian-developed framework that provides very clear examples of conceptual components for learning health systems. If you're interested in learning health systems and haven't already come across this, I highly recommend this reading. At the center of this framework represents the work of learning health systems called learning cycles. And these three-stage cycles are processes where you first collect practice-based data. You analyze and format that data in ways to be used in decision-making for further improvement or to inform future innovation. And then finally, this knowledge that came from routine care is integrated with research evidence and applied and studied once again to support care processes and practices. And we study the system in this cyclical way to continually improve and ultimately deliver greater value care. So these learning cycles can be focused on anything really, specific conditions, safety measures, workplace policies and processes, like whatever, and any number of cycles can be going on at once within the same learning health system. At the center of each learning cycle is a community of interest, and these communities include perspectives from all relevant stakeholders, and they identify healthcare issues and then set learning priorities. And it's these learning priorities that really drive the focus of any learning cycle. So for our case, the cycle our model supports is to learn about implementation and improvement methods that work in Alberta. Our community of interest sees the potential to embed implementation and improvement research into healthcare as a means to standardize implementation planning and evaluation across the system, so to build some common measures that help us learn from all implementation efforts. In this way, we'll be able to accelerate scale, spread, and sustainability. We want to optimize implementation strategies to increase the efficiency and effectiveness of implementation and improvement. And we want to be able to identify the value of various implementation approaches. Back to the framework, this framework also highlights various core values and pillars that support these learning cycles. So these pillars represent different infrastructures and resources required to do the learning and then to spread learning across the system. So for the sake of time, I won't get into each of these. But for an implementation-focused learning cycle, Alberta does have a number of key infrastructures in place. We have a science-focused culture in the health system that values evidence-based medicine. We have quite a few organizations with highly qualified people that support implementation and improvement capacity. So Alberta SPOR would be an example of this. There's teams both for QI and implementation in the health system that support that. There are strategic clinical networks, there are academic teams that are supporting continuous medical education, these types of groups. We also have improvement expertise and a dedication to professional development. So many people are accessing training through Intermountain Healthcare, Healthcare Excellence Canada, Knowledge Translation Canada, Institute for Healthcare Improvement. And then finally, we also have very strong analytic capacity in Alberta. We have various data repositories. We have services to access those repositories. There's supports to analyze the data that's accessed. And then we also have world-class artificial intelligence expertise here. So here's our learning health system model. This is an initiative that we call the Implementation Science Collaborative. And this model was built to support implementation and improvement science by coordinating existing processes and actors in our system. It was really important to us to coordinate existing actors rather than to build a whole new office. We wanted to simplify processes and help people do their existing work rather than to add complexity to it. So we do this by bringing together health system leaders and users. This is this group in green, our steering committee. They come from various care communities, including clinical settings, primary health, Indigenous health, patient advocacy groups, like all sorts of people, to tap into local practical knowledge of widespread implementation barriers. So this would represent the community of interest in our implementation-focused learning cycle. We also have a scientific advisory board that is comprised of international implementation science leaders. They examine the practical barriers and develop implementation research designs and measures to embed into health system innovation projects. And these experts would be considered part of that scientific infrastructure required to initiate learning cycles. Alberta SPOR is represented by this purple group. We promote the research recommendations developed by the Scientific Advisory Board. We identify well-suited project teams from the innovation community, so that's this blue group. We broker and facilitate embedded research relationships, coordinate data capture and analytics, and catalog lessons learned to inform future implementation province-wide. So this is really the process of coordinating those learning cycles. So before we could actually start to build this model, we had to do some foundational work. We believed that Alberta was set up to support a learning cycle around implementation, and we were really excited by the idea of being able to coordinate bringing scientific rigor to implementation and evaluation of healthcare initiatives in real-world settings. But we recognized that this would require major coordination between various health system, academic, primary care, data, all sorts of actors that have traditionally been siloed from one another. So to assess the province's readiness for something like this and whether it was worthwhile for us to launch into this work, we held 2 large stakeholder engagement events, bringing together over 100 people from academic, health system, government, all sorts of groups to assess the province's readiness for this. And we did this in a number of ways. First, we explored implementation that was already going on in the province and asked those groups how something like this could support their work. We conducted a SWOT analysis as well as a value proposition with event attendees to gather as much information around the facilitators and barriers and how to really make this initiative valuable to the community. And we wanted to collect this information from as many perspectives as possible. So in Alberta's case, we found that this was something that stakeholders wanted to move forward with. So we wanted to help coordinate. So we proceeded with some foundational research required to get this initiative off the ground. Specifically, we conducted an asset mapping study and then a social network analysis of those assets to learn which Alberta-based resources exist and where the gaps lie to help inform how we build our initiative. To learn what assets exist in Alberta, we surveyed folks in our own network and used snowball techniques to learn who in Alberta is doing implementation science and practice and who's already collaborating with one another. So now we feel like we have a comprehensive asset inventory, and mapping all of the actors in this inventory and sharing the maps back with them helped clarify why certain gaps exist, which processes and policies facilitate implementation and collaboration, and that sort of thing, to give us a much deeper understanding of the implementation landscape in the province. While we were conducting our asset mapping and social network analysis, we fleshed out our steering committee, which was our multi-stakeholder implementation community of interest. With this community, we co-designed our learning health system model. We built and tested the prototypes with them and refined these as we learned more about Alberta's broader implementation landscape. And co-designing the model with this committee has been absolutely critical to building the model in a way that would work for Alberta, meet the needs of our various stakeholders, and help us at Alberta SPOR fulfill our mandate of supporting Alberta's learning health system. So I hope that this presentation of our process and resulting model has given you some ideas of how to start building your own learning cycles or coordinating learning health system infrastructures. And I'm happy to field any questions you have about our processes and models. So thanks for listening.